Hello, this is Daniel Wolff from the University of Regensburg, Germany. I am chairing here the GvHD Center, which provides treatment for patients with transplant in the region for chronic graft-versus-host disease, but also provides a second opinion for patients transplant at other transplant centers. With this, I want to start covering the question, what factors drive the decision from switching from first-line treatment of chronic GvHD disease to the next line, second-line treatment. I just want to briefly mention what types of treatment are used in first-line treatment. The mainstay is steroids, which may be combined with either calcineurin inhibitors, mTOR inhibitors, or rituximab, and in pediatrics, sometimes ECP. This decision on first-line treatment does not really impact the decision when to switch to second-line treatment, but has to be kept in mind. Mainly because some patients show mixed response, and in mixed response is always good to consider staying with for a while with what you treated before, adding another agent, then switching off the most toxic component of the prior treatment line, while if a treatment doesn't work at all, you just switch. But the question is when to switch and what is driving the decision. First of all, any line of treatment requires an thorough response assessment. Does my treatment work and is it tolerated? Those are the two questions which need to be answered. Usually first time for kind of response or efficacy assessment is at 2 weeks, not in terms of efficacy, unless the patient is clearly progressing at that time, but more for toxicity. Does the patient tolerate? And if there is no clear rapid progression, the time for first response assessment is 4 weeks after you switch to treatment. Asking the question, do I see any improvement? Do I see worsening? And worsening would obviously trigger a next treatment line. Then do I see stable disease? And when to switch is a more difficult thing. If I don't see any minor change, then the question is, would there be any change expected in future? And the time until you wait depends on the toxicity of the treatment and the symptom burden of the patient. So if a patient has very mild symptom burden and low steroid dose, then you can wait, and no toxicity, you can wait a little bit longer and no change. If the patient has a high symptom load or toxicity on the treatment, then no change would obviously drive earlier a switch to the next treatment line. Partial remission is a tricky point because some of the organs you treat won't get significantly better. That's true for ocular GvHD disease or SICA, symptoms of all GvHD disease. Those symptoms rarely improve significantly, while inflammatory changes usually resolve more on a quicker path. So an inflammation still detectable at 3 months of treatment is obviously not going away for the next 3 months, while minor improvement of sclerotic changes may still go better for the next 3 months. So partial remission is not partial remission. And the earlier you assess your treatment response and the more inflammatory conditions you deal with, the earlier you would expect your response to be seen. And again, partial remission should be assessed at 6 months, and then asking the question, would there be any treatment which would still further improve your partial remission, maybe to complete remission, or improving the quality of partial remission? Usually, as long as a patient gets better and the treatment isn't toxic, meaning low dose steroids, where is time to wait? If the symptom load is still significant, or you have inflammation ongoing, or you have significant toxicity, then you need to switch to second-line treatment. And overall, to summarize that, switch is indicated in case of progression through 1 month of treatment, lack of response after 3 months of treatment, or insufficient partial response at 6 months of treatment. That can be shaped, this time frame, by some consideration, especially in children. Higher steroid doses in a steroid-dependent diseases would drive your decision to second-line treatment because of the toxicity of steroids in a growing child. Now, having said that, there's another population which is highly steroid sensitive. Those are older patients, older than 60 years, when steroid toxicity is way higher than in younger patients who may recover better. The other question you also need to answer is, what is the organ involved? Is there any high-risk organ with a significant risk for complications like lung GvHD disease, where you really have to eagerly follow patients, not missing a progression, and if you see progression, not to wait until a significant part of the lung is gone. And in lung GvHD disease, also infectious complication may drive your decision to switch. I don't want to mention details on the options in second-line treatment, just to mention two. In Europe, ruxolitinib is approved for second-line treatment, and that's the mainstay, main choice of treatment for second-line treatment. Having said that, there are some patients who may not be eligible for ruxolitinib. First of all, patients with progressive onset developing chronic GvHD disease on ruxolitinib are obviously no candidates. Second, ruxolitinib can increase cytopenia, which if already existing before, and this would be a population where you need to consider something else. And then patients with ongoing infectious complication may be not ideal candidates for ruxolitinib, and those patients would be candidate for ECP mainly. And there are very few patients who already burned their ruxolitinib during treatment of acute GvHD disease, meaning the progressive onset patients, and those would be patients eligible for belumosudil. I hope I made some statements which are helpful for you in treatment of a chronic GvHD disease, switching from first-line to second-line treatment. Maybe one last word. There is a significant need to separate steroid non-responders versus steroid-dependent patients. Steroid non-responders, meaning progressing disease on a full dose of steroid, 1 milligram per kilogram per day, need to be rapidly switched and need to taper their steroids. They do not work anyway, while the steroid-dependent patient would usually first respond to steroids and lose the response, and latest after the second attempt to lower steroid dose below 0.5 milligram per kilogram, you need to switch to second-line treatment. That's something to be considered, because steroids on the long run, don't need to tell you that, are pretty toxic.